So I've already welcomed you to Las Vegas, and I need to congratulate NOCR for getting into its 19th iteration. I have very specific objectives that I've been given because I've wandered in the past, I think, and they don't like me to wander. So I'm going to stick to these things: choosing a frontline agent, selecting an agent for relapse, and the question of who are candidates for immunotherapy. So just going back to the basis of what we know, Memorial Sloan Kettering classification allowed us to divide patients for clinical trials in our clinical practice with set parameters. There are some iterations of this that use similar factors, and in fact this has been used in a variety of other cancers since to help us classify our patients, not just for trials but also for practice. If we look at the jelly bean diagrams of what we know in renal cell cancer, there are a couple of dominant pathways. The first is obliteration of activity of the von Hippel-Lindau gene, as you can see on the schematic. This leads to activation of other jelly beans, HIF1 alpha and also HIF2, to induce angiogenesis, with a whole lot of angiogenesis factors technically acting outside of the epithelial component of renal cell cancer and producing a phenotype that's very vascular. If we move across to the other dominant pathway, which is mTOR, you can see here that an activation of P10, as an example, would induce mTOR and AKT activity, and then also activation of angiogenesis. But in addition to that, metabolism and proliferation are switched on. The problem is that we're now about 20 years into understanding that these two processes were important, perhaps 15 for mTOR, and we're now going to get some data from the TCGA in the next few months about the various components of mTOR and other pathways. So we'll learn some more. The question will be, with those deep sequencing projects that we've invested lots of dollars in, whether they're going to actually tell us how to manage the patient. And we are going to need some biomarker studies that pick up on that. So we've had a lot of activity. To the left of this diagram, we have interleukin-2 and interferon alpha, which is where I actually started therapeutically. And coming to the United States in 2000, I was given 2 phase 1 studies at USC. One with a drug that became sorafenib, the other with sunitinib. And the biggest problem I had was that they put the blood pressure up. And so we had to manage that because it wasn't in the protocol. So I was very glad to see that they had activity in renal cell cancer, which had been gifted to me by my boss at USC. He said, "You can do renal cell. Nothing will happen in this disease. I don't want to see it, and you can have it." So subsequently, we did a few trials and met with some success where we've got a cascade of 7 different agents that have activity in the disease, at least definitively prolonging progression-free survival, and we have another couple to come at the end there, as you can see on this diagram. So we have a problem in that we're spoilt for choice, and in picking a frontline agent, we have made some advances. Up the top here, we have the interferon regimens, which produced progression-free survival of the order of 3 to 6 months, and which were heavily marketed in something called the interferon wars that I found very bizarre when I was a fellow. Have we progressed beyond the interferon wars? Well, some people would argue that we haven't. We've just got a series of people competing for the usage of our therapy with VEGF-targeted drugs and mTOR-targeted drugs. And from that perspective, I'll try and look at this a little bit as we go through the COMPARE study. We are prolonging disease, and we have improved overall survival based on American Cancer Society statistics for advanced disease, not just for the disease overall. Now, I put the arrow in here because we start with the arrow. Has anything changed in 2013 in terms of what we're doing with our therapeutics, or late 2012? And the answer is, yeah, there is one thing, and that is that I think we've moved up Pazopanib as being a competitor to sunitinib, and I'm going to show you the COMPARES data. The other things that I've highlighted here have question marks next to them. So you can see that in terms of first-line therapy, I have tivozanib and exitinib, where we do have some data with question marks next to them, because I don't think the data that's been produced in those phase 3 trials necessarily is definitive for using those drugs as first-line agents. Indeed, exitinib is approved as a second-line agent. So I'm going to predominantly talk about sunitinib and and Pazopanib. But first, a little bit of history. In 2007, this paper was published in the New England Journal of Medicine in parallel with a paper that showed the activity of sorafenib in second-line therapy after interferon alpha. We've become rather bored with these data because we doubled progression-free survival. Big news at the time, and sunitinib became a standard as first-line therapy from that time forward, and 2/3 of you certainly believe that. In 2008, renal cell cancer got kicked out of the bucket club, which for those of you who don't know, it's different to the film. It's actually 2 years, not 1 year. So the overall survival data showed us for the first time that in a relatively unselected metastatic group of patients, we could get survival beyond 2 years. Unfortunately, several factors led to this trial having a p-value of 0.051 and questions over whether we advanced survival or not. Just to make the point that when we did trials with Hodgkin's disease in the 1980s and early 90s, none of the studies were significant, but the survival trebled. And so from that perspective, we're not able always to illustrate these things, but these drugs do improve survival in this disease. It's a question as to whether our trials are good enough to demonstrate that. And then the Pazopanib trial, which was a mixed first and second line study of Pazopanib versus placebo, designed at about the same time that we were designing the target study in renal cell, and given in a different sort of geographic distribution. Patients were allowed to have had one cytokine before, and about half of them had. To summarise that data, it's pretty boring. Double progression-free survival compared to what was the standard, nothing. And then OS improved, but not statistically significantly with the drug. So a couple of drugs with significant activity. We're left with a problem of selecting first-line therapy, and this is the Three Stooges summary of how we select therapy. In the first line, we do look at cytokines as an option for good risk, although that's been questioned with recent cytokine working group data as to whether we can actually get complete responses, certainly in intermediate and also some poor risk patients. Generally, for the intermediate patient, who's the most common patient we're asked to treat, in this country we use VEGF TKIs, although Bev and interferon is a reasonable alternative. And then for poor risk, we have good evidence for mTOR and some evidence for sunitinib, and I'm not going to talk about that today unless there are questions. The COMPAS trial, a first-line phase 3 trial comparing Pazopanib to sunitinib, was presented in a clandestine meeting called ESMO in Vienna last year. We had 4 major presentations on renal cell cancer. It's not a conspiracy against the United States, but we have trouble getting renal cell cancer and GU abstracts presented on a podium at ASCO. And also the timing as to when these trials came out meant they fitted with ESMO a bit better. So this is a first-line non-inferiority study. And Dr. Nannis helped us earlier with a description of the SWOG 9346, also a non-inferiority study. So the primary endpoint was PFS, and then they also looked at OS and patient-reported outcomes and quality of life. So this is the design of the study. 1-to-1, clear cell histology, and the patients had to have demonstrated metastatic disease. They were stratified for whether they had prior nephrectomy or not. Pazopanib was given continuously every day, sunitinib on the 4-week on, 2-week off schedule that we're familiar with. This is the primary endpoint outcome. And in order for Pazopanib to be considered not non-inferior to sunitinib, they needed to get inside the confidence bound of 1.25, 25% difference. And so you'll see here, they just made it, 1.22 in an underpowered study. And I haven't got into the power or the stats, but you can see that sunitinib was 1.1 month better than Pazopanib at the median. I don't think that indicates it was better, but these drugs are probably equivalent. In terms of response, there was a slightly better response overall to Pazopanib, but the disease control rates, the non-growth rates for the two agents were very similar questioning whether we should be looking at response or not. Overall survival, the curves pretty much overlap, as you can see there, with a numerical slight victory to sunitinib, but a p-value that's very non-significant. So for disease-controlled and overall survival parameters in the first line, these two agents appear similar. Duration of therapy was similar between the two, as were dose reductions and discontinuations of each of the therapies. What about the toxicity, which ends up being probably the game breaker in the two evaluations? Now, sometimes we design trials and we try and make them fair. That's what I try and do, because I'm that sort of guy and because I usually do cooperative group studies. But GSK designed this study and the trial wasn't fair. The fight was not fair. It was like something that would happen at Caesar's Palace where it's rigged. But what happened was that the assessment of quality of life occurred on day 28 in this study. So as you're dosing pazopanib continuously every day, it probably doesn't make that much difference. But sunitinib, when a patient gets to day 28, most of my patients are green from the secondary metabolite. If they're not green, they feel green, and they're looking forward to that 2-week off. So the evaluations were done for toxicity and quality of life on day 28. So this was actually not a fair fight, but having said that, I think that this confirms what we know. The toxicity evaluations indicated that pazopanib was worse for ALT and also AST increase than sunitinib, and this is liver enzyme increase is a major problem with the drug. And also, obviously, hair colour changes are worse with pazopanib. If you want to be a bleach blonde, like most of the women that seem to be here in Vegas, then pazopanib probably is the drug for you. So sunitinib looked like it was slightly worse for fatigue, but not much. Hand-foot skin reaction worse with sunitinib. Taste alteration, thrombocytopenia worse. Many of us would have predicted that from the beginning. The quality of life data in the first 6 months I do have some issues with, and this is being reviewed at a major journal at the moment. So you can see that the majority of these parameters favour pazopanib, which I believe clinically to be correct. But there are issues, for example, with the FACIT-F fatigue score, where a significant difference for a patient is 3. The median difference was 2.32. And so from that perspective, these are statistically significantly different. But I sort of got a question when we use these quality of life parameters to be the game breaker, just what they mean. Now, that doesn't mean that I think quality of life is overall likely to be better on sunitinib and that these results are just plain wrong. I just think that the study wasn't designed that well. And I can leave you to interpret things for yourself in looking at that. So the yellow is a victory for pazopanib over sunitinib. So the study demonstrates non-inferiority for pazopanib compared to sunitinib. The data support that pazopanib has similar efficacy in terms of response rates and overall survival, and there's a differential safety profile between the two drugs that leads us to make an assessment as to what the relative risks are for our patients. And the quality of life assessment favours pazopanib over sunitinib. I agree that it does, but I think that the way they did it perhaps was a bit skewed. So I always worry about non-inferiority studies. As someone once said to me, same, but different, what does it really mean? And a non-inferiority study, as Kathy Tang, and the SWOG GU statistician, once said, she said to me, it's like kissing your sister. And I said, okay, well, you haven't met my sister. And she said, well, would you have a choice between kissing your wife and your sister? And I said, okay, I take the superiority study. But I think it is important for us to do these studies and for them to be powered. Is there really less toxicity, or is it just different with a better quality of life? That may be academic, and I think we have a choice in practice now and some education on that. How will you adapt this? Well, I'll find that out in the question we ask you again in a little while, hopefully. And where are we going to use exitinib and tivozanib as agents in the first line, if at all? Rhetorical questions. My second objective relates to looking at an agent for relapsed disease. And many of you will have had a Zen Buddhist moment in Vegas. And I realise we haven't got to Sunday yet, but I know that many of you are very observant for your various deities and religions. From that point, a Zen Buddhist moment here is a moment that's been created where we didn't have it before. So before we had first-line therapy, we didn't have second-line therapy. So into that space came Record 1, a trial that looked at one or two VEGF TKIs in advanced disease and randomised them to everolimus, an oral mTOR inhibitor given daily, versus placebo. And this showed a major progression-free survival advantage for everolimus, as you can see here, with a doubling or more of progression-free survival that led to a stopping of the trial and a crossover to patients. There was no overall survival advantage in the study, perhaps because of the design, although we'll never know. Very effective drug compared to placebo. If we look at giving a VEGF TKI in the second line, this study, the AXIS study, examined this in patients that were allowed to have any one of a series of first-line therapies, including cytokines, sunitinib, temsirolimus, or bev interferon, and randomised them to exitinib, a new, more preferentially targeted drug for VEGF receptor, versus sorafenib, which is a multi-kinase inhibitor and the first drug licensed in the disease. This is a summary of the data, which showed a progression-free survival advantage of 2 months at the median to exitinib over sorafenib overall in the study. It also demonstrated differential toxicities. Hypertension and hypothyroidism more common with exitinib, hand-foot skin reaction, rash and alopecia more common with sorafenib, and discontinuation rates that were not terribly different but which favoured exitinib. More importantly, after cytokine therapy, the patients seemed to do particularly well on VEGF TKI therapy, and in the cutout, the patients that got interleukin-2, high-dose interleukin-2, there was a third of the population, 87 patients with cytokines, actually did even better, and we have a paper coming on that. So the message was that if you gave cytokine therapy first, particularly high-dose interleukin-2, you didn't lose much in terms of giving a powerful VEGF inhibitor in the second line, at least in terms of PFS. After sunitinib, there was a difference in favour of sorafenib, but perhaps not as much as people would have thought. The data in the other two groups are not large enough for us to come to any conclusions. So then comes to another ESMO abstract, and I know that many of you would have enjoyed being in Vienna. I went and was stung by a tick and got some rickettsial thing that knocked me on my you-know-what for a while and gave me arthritis, of which I'm now recovered. But apart from that, the data were interesting. And the question we've had is, in the second line after you've got a VEGF inhibitor, do you give an mTOR or a VEGF? And I just showed you data for everolimus and exitinib, but a trial had been previously designed by Wyeth before it was swallowed by Pfizer to look at temsirolimus and sorafenib in this setting. The Intersect Study, and they renamed it right at the end, it was called the 404 Study. And the 404 Study, you know what 404 is? If you put a wrong address in on the internet, you get 404 error. Now, I don't know why they called it that, but they called this the Intersect Study. And these were patients that got in the first line only sunitinib. 2/3 of you liked this drug in the first line for our 73-year-old redneck from Central California. And they then said, okay, after you've progressed, you're going to go on to temsirolimus or sorafenib. Primary endpoint progression-free survival, treatment until that point, and then follow-up until progression and follow-up for death. So primary endpoints were progression-free survival and determined by the so-called independent radiological assessment, a blinded radiologist sitting somewhere in Bangalore, India, making a determination on what to do with the patient. One of the secondary objectives was PFS by the investigator. There was no difference between these two, and there never is, and the FDA now thinks they're going to do away with the blinded radiologists in Bangalore. It's just a question as to who's going to tell him. So secondary endpoints were response and overall survival. So statistical design is not terribly important. You can read it as it gets published, but basically PFS and OS were the key deals. So progression-free survival, both of them are about 4 months. Numerical slight difference in favour of the mTOR inhibitor, statistically not significant. Response rates, it's almost exactly the same. In fact, it's boring between the two. Duration of response slightly favoured temsirolimus. Overall survival, more than 4-month advantage to sorafenib. So you're kind of silent looking at that because you probably haven't seen this data before. There was silence in the room at ESMO for about 30 seconds. And then in medical meetings, incidentally, I assume you're all docs here, right, or clinicians. In medical meetings, doctors don't show up anymore. It's the street. It's investors. So they all flux out. And Tom Hudson's standing there. And they go out and they say, what's the message? Sell Wyeth. Sell Wyeth. And of course, Wyeth was consumed by Pfizer 4 years before and contributed a lot of things that are probably important to Vegas, like the oral contraceptive pill. One of the towers here is built on the oral contraceptive pill, another on tobacco, gambling, etc. But from that perspective, they all rushed back in to get the rest of the data, and this was important to me. So in terms of overall survival, there was not a statistical difference if the patients were on sunitinib for less than 6 months, 180 days. But sorafenib did better, significantly better by 3+ months if they'd been on sunitinib for more than 6 months. So we'd been looking for these data for a while, and I think this tells us that if patients do well on first-line VEGF therapy, then second-line VEGF therapy may be a better option for them. And we've thought that in our bones, but this is evidence for that. Subgroup forest plots are often fascinating. These are not, except that for the no nephrectomy patients, the Toracel did a little better. The subgroups are interesting down the bottom here, and what's coming out in a series of studies is that if you look at sorafenib in the intermediate group or the ECOG 1 patients, who I don't see ECOG 0 patients very often, it's very difficult for us to beat that drug. And several studies now sort of show that. And so something old that many of us had not used much anymore may still be useful. Adverse events was really very much as expected in terms of between the two, and I won't dwell on that in the sake of time. So the summary was that the primary endpoint was negative, but this study informed us of a lot of stuff, and it produced the largest overall survival advantage we have seen in renal cell cancer in terms of hazard ratios. And so from that perspective, I think is informative. I don't know what it means, but certainly it's made me a little bit more reticent to give Toracel in the second and third line. And so the questions are, what should we be treating to in our studies of renal cell cancer? Overall survival or PFS? We've used PFS universally. Toracel, or temsirolimus, sorry, not meant to use the brand name, is used in 30% of patients second line in the USA. And there are reasons why you may want to infuse, but we have, this is the only evidence we have, and I think I'd be skewed to say it's negative. And sequential therapy issues still need work, and I think we need some biomarkers here to help us. All right, so those of you who were at the Elvis lookalike competition the other night, nice job. The people in Vegas these days seem to look like the folks on the left who are on the other side of the fence. And adopting new therapies for immunotherapy, one would assume that the Elvis impersonators are candidates for if they get renal cell, whereas the folks with the little dog on the other side do not look like candidates. So how do we select? Well, we go back to this data, which is now more than 20 years old, and we look at why high-dose IL-2 was approved. And you can see here the reason it was approved was it produced durable responses and cures in those patients who got a complete response. What has happened in the subsequent 20 or so years since we put these data together is that the patients who get a partial response are doing better. So that some response is better than no response. And we have seen a renaissance in the use of this agent in the last couple of years. So at USC we got down to doing about 15 or 16 a year. We're now back up to 45 a year in renal cell and melanoma. And we had to actually retrain some people to give it just to have a broader base. So this is a curative agent. Surgery for solitary metastases is also curative, and we need not to forget that. But there's some new immunology coming. And I'm not going to go through this in detail, but the PD-1, PD-L1 pathway was well iterated in one of the lung cancer talks, and a similar diagram was shown. We have some data with this agent, and there are several of them. It just happens that one is in the lead at the moment. And there is data in renal cell cancer that we can switch on this effect. In a study with what is now called nilotinib, which is a BMS telephone number compound that they've given a name to, there was some activity in renal cell with a response rate of around about 25 to 30%. And real responses. This is a patient who's had 4 prior targeted agents, had not had IL-2. And so we do see real responses with this. Importantly, there's a marker, PD-L1, that appears to predict response. And we have to test this, and going forward we'll be looking at this in studies. Immunohistochemistry marker is not hard to do, and we can actually stain for this on circulating tumour cells reasonably predictably with immunofluorescence. So this study is moving forward. It's a second-line study of everolimus or nilotinib. So they're going to compare to what they think is the standard, different agents, an infused therapy given every few weeks compared to an oral one. So what have we learnt? I've learnt that my time's up and I better get off, or Jim won't have me back. Parenthetically, choosing a frontline agent, we have a choice within drug classes. Most of us are going to give a VEGF TKI unless the patient qualifies for high-dose interleukin-2, and I'd advise you, if they do, to send them to a centre that does a lot of it. Don't try this in your small community hospital, because our mortality rate, for example at USC in the last decade, is a mortality rate due to therapy of 1 out of 712. Whereas if we look at the community who've treated the same number of people in Southern California, their mortality rate is 9%. So they've killed more people than we might have cured with the agent. So big centre for those patients. The newer agents may offer incremental efficacy, or they may not actually be significantly better. I don't think pazopanib's better than sunitinib at controlling the disease, but it may be less morbid if you pick the patient right. For relapsed disease, we still have a choice between VEGF and mTOR, and I think the pendulum has swung back a little bit towards sequential VEGF TKI therapy, especially for those patients who've had a prolonged response, maybe beyond 180 days with a first-line VEGF TKI. Who's a candidate for immunotherapy? This is very much a moving bus. I now treat patients into their 60s, provided they are fit and do not have major comorbidities. And the latest cytokine working group data suggests that we perhaps should be not just offering it to good risk patients, but that may be just a reflection of the fact we don't know what we're doing. I think novel targeted immunotherapies are going to have traction, and certainly I'm glad to have some new therapeutics to target that immunotherapy group of the immunotherapeutic milieu in this group of patients. Thank you very much for listening, and I'll hand back to our chair, Dr. Nannis, for some questions. Thank you.